So good evening, everyone. So we were taking into consideration. So I'm Rizwan, first of all. Um, Happy to see a lot of you here. So we were getting a lot of feedback about how we should be having more discussions about not just theory, but stuff that they can ask in Vivas, especially for the ones who practice for the institutes of national importance, as well as it's always good to learn stuff through images. So I thought we'll do this a little bit in between the theory sessions. Usually we had this tendency to do this after our theory exams, especially for the INSET and before the practical. But people were suggesting that if we could do this intermittently, it'll be like a refreshing session also. So what we'll do is, I thought we will do this session of something called a potpourri. This is where you try to have a mix and match of various topics. I'm not just going to restrict myself to one particular area of gastroenterology. I'll be primarily dealing with gastroenterology, not hepatology, but I'll be going through a mix and match of stuff. And there'll be a mix of images, videos, radiological images, x-rays, and stuff like that. And usually they will be in association with some form of a clinical case scenario. So with this, let us start off with the case scenario number one. I have a 45-year-old male who presented with long-standing dysphagia and regurgitation with recent onset chest pain and weight loss. I'm going to show you the endoscopic findings of this patient. The question is very specific. How are you going to evaluate the severity of his condition? But you will not be able to do that unless you know what diagnosis we are talking about. So let us look at this endoscopic image and a video. So this is an upper GI endoscopy. You can see that there is a lot of food stasis and liquid stasis. The esophagus is hugely dilated, and at the level of the gastroesophageal junction, there is severe narrowing. When pressed forward, I go inside into the stomach. So as you would all have guessed, that is a classical case of an achalasia cardia. This is a particularly extreme form of achalasia cardia. In majority of cases of early achalasia cardia, the endoscopic findings may be normal. But in very advanced cases, you have an S-shaped curve or a sigmoid-looking esophagus with a lot of food stasis, but there will be no mucosal growth or obstruction. The obstruction will be felt at the level of the gastroesophageal junction. So technically, it is the ICARD score that is used for assessing the severity of achalasia cardia. These are the four cardinal symptoms that we deal with. So patients will have dysphagia, regurgitation, and in later stages, they may present to you with chest pain as well as weight loss. Based on this, there is a scoring system, 0 to 3. And this is also a useful tool to find out whether there has been an adequate response to whatever treatment that you're offering to these patients. If there is a score less than or equal to 3, that means whatever you have intervened in for this patient is effective. But this alone is not enough. What other tests will you perform to confirm the diagnosis? Just an upper GI endoscopy is not enough to make a diagnosis of achalasia cardia. Especially in the early stages, the endoscopy can be absolutely normal. So what usually happens is when we do an endoscopy for a patient who's got dysphagia, the endoscopist gets a feel that there is some kind of a dilatation of the esophagus and a narrowing at the level of the gastroesophageal junction. We get our suspicions right, and we would like to do further investigations. One of the cardinal confirmatory tests that we do is esophageal manometry. So if you look at this particular person, two things are mentioned here. One is something called pan-esophageal pressurization and an IRP of 35.3. So you don't need to mug this up. What we're trying to say is just remember this thing called integrated relaxation pressure. So normally the concept is that in normal people, when I swallow something, there has to be an immediate relaxation of my lower esophageal sphincter. There is a relaxation of the lower esophageal sphincter. That's what usually happens as soon as I make a swallow. When that mechanism fails, that is the starting of what we call an achalasia cardia. So what happens is IRP, or integrated relaxation pressure, measures the level of pressure at the level of the LES during the time of swallowing. For normal human beings who do not have achalasia, that value is less than 15. So whenever you come across an integrated relaxation pressure more than 15, in this case is 35, that is most likely a classical finding of achalasia cardia. And much more commonly, what we do, this is an old school technique, is the barium swallow. So if you pay attention to this barium swallow, you notice that the barium is being swallowed into the esophagus and it is trickling down in the stomach with a definite narrowing at the level of the lower esophageal sphincter. So even though the liquid secretions are passing on into the stomach, there is a stagnation in the level of movement of barium inside into the stomach. This is classical of achalasia cardia. There is no filling defects inside, there is no mucosal abnormalities, but there is a holdup of barium within this. So in majority of people, around 90%, most of the barium will get extruded within 1 minute into the stomach. In 100% people, it will not take more than 5 minutes. In majority of the normal people, the maximum time it will take is 5 minutes, but in around 90%, it takes just less than a minute. Whenever you have a delay like this, you have to suspect achalasia cardia. So if you look at the image on the left and if you look at the image on the right, one interventive endoscopic procedure has been performed in this patient. So you focus on the before the procedure is the image of a barium swallow. There is a holdup of barium within the esophagus and there is streaky fluid going into the stomach. Now you focus on the right. On the right side, this is the swallow that is done after a particular therapeutic procedure has been performed. So if you get a question like this, you see that there is an absolute passage of the entire liquid into the stomach. So this patient has undergone a procedure that is called per-oral endoscopic myotomy. It's an endoscopic procedure. This is the treatment for achalasia cardia, among other possibilities. If you are perceptive, you'll also notice that there is slightly a different finding here below the diaphragm on the right side. This is technically air in the diaphragm, but this is actually carbon dioxide. We use carbon dioxide when we do a procedure. And because we are opening up the posterior myotomy or posterior wall of the esophagus, there is a chance that you can have, this is one of those situations where you see air under the diaphragm on an X-ray and you don't take it very seriously because it's a common occurrence post-myotomy in these patients. So peroral endoscopic myotomy is one of the endoscopic therapeutics for achalasia cardia, and whereas this is the image of a normal barium swallow. In a normal barium swallow, there will be a brisk passage of barium inside into the stomach. There is no narrowing or tapering of the lower esophageal sphincter. You try to actualize these images in your mind so that when you come across them in future, you will try to remember. So this is, now we have talked about something abnormal, that is achalasia cardia, just to give you an understanding of what is normal. So this is an image of a normal manometry. Don't try to mug it up. See what you can understand. Maybe when you read about, whoever is interested about this, so can read about more about this. So this is a manometric, esophageal manometry, which is usually a high resolution manometry, is actually a pictorial representation of a dynamic pressure monitoring of various aspects of the esophagus. So here you have the pressure measurement, and here above is the upper esophageal sphincter. Here is the lower esophageal sphincter pressures. Along this axis, you have time. So when you perform an esophageal manometry, the measurement shows a graded contraction of the esophageal musculature from the upper esophageal sphincter into the lower esophageal sphincter. The so-called warm colors are the red and the yellow. The so-called colder colors are blue and green. If you look here, this red color is a high pressure wave that is progressing very normally across the esophageal musculature, which is what makes this a normal manometry. But what is very important for you to understand is at the lower esophageal sphincter, as soon as the contraction starts from the upper esophageal sphincter, there is a concomitant relaxation of the lower esophageal sphincter. This is the classical mechanism of a normal swallowing. When this becomes faulty, you have an abnormal manometry, which denotes that there is an abnormal esophageal motility disorder. Not all motility disorders need to be achalasia cardia, but this is the most common and easily treated motility disorder. And even amongst achalasia cardia, there are 3 forms of achalasia cardia. I will just try to be brief. The basic thing that you should understand is that in all the 3 types of achalasia cardia, one thing is common. the integrated relaxation pressure will be more than 15. If you cannot remember anything else, at least remember this. The baseline lower esophageal sphincter at the time of swallowing will be high, more than 15. So if you look at this, it is 21, it is 35, it is 40. All these are various forms of achalasia cardia. The most common form of achalasia cardia is type 2 achalasia. This is what we all come across. In type 2 achalasia cardia, instead of that sequential progressive wave that you see along the esophagus, what you see here is a similar wave or a similar pressure that is seen throughout the length of the esophagus. This concept is called pan-esophageal pressurization. So pan-esophageal pressurization means that instead of a sequence of a contractile wave traveling down the esophagus, you have a similar pressure wave happening within the length of the esophagus, which is not propulsive. So that is not going to aid in the conversion or a transfer of food from esophagus into stomach. This is the classical feature of type 2 achalasia. Whereas in type 1 achalasia, if you notice carefully, there is no wave here. There is an absolute absence of any kind of a pressure wave. So that concept is very classical for type 1 achalasia. It's an aperistaltic esophagus. Whereas type 3 esophagus is the rarest form of achalasia cardia in which you have premature contractions, premature high volume or high pressure contractions of the esophageal wall, but it is not happening sequentially. It is happening at an erratic phase. So it can be very similar to something called a diffuse or a distal esophageal spasm. Type 3 achalasia cardia can be similar to a spastic esophageal disorder. So type 1 and type 2 belong to achalasia purely, whereas type 3 achalasia can also be called as a spastic esophageal motility disorder. The three main modalities of treatment for achalasia cardia is endoscopic management is peroral endoscopic myotomy. Endoscopic balloon dilatation used to be classically done before, but it's no longer done very commonly because it's not very effective. Secondly, there is a risk of esophageal perforation. But what you should know importantly is that the kind of dilatation that is done specifically for achalasia is pneumatic dilatations. It's air-based dilatation, whereas most other dilatation for strictures, it is based on contrast or liquids. The surgical management of laparoscopic Heller of achalasia cardia is laparoscopic Heller's myotomy. Now, the efficacy of peroral endoscopic myotomy and laparoscopic Heller's myotomy is similar, except for type 3 achalasia, where POEM is more effective than laparoscopic Heller's myotomy. So, coming to the clinical scenario number 2. So, here you have a 75-year-old male patient of CKD who presents to you with repeated episodes of vomiting associated with hematemesis and melena. On evaluation of the ER, he was hemodynamically stable. His hemoglobin was 6.5. As the on-call gastroenterologist, what is the first order of business? So this is a tricky question. You shouldn't say that you will immediately want to do an endoscopy. What you're going to say is that they have very clearly told you that the HB is around 6.5. So the baseline HB that is required in a patient is at least 7 gram per deciliter before you do an endoscopy. So this is why, even though the time period between the presentation and doing an endoscopy is important, we don't do hyperurgent endoscopies. You don't do an endoscopy at the risk of not stabilizing the patient. So you have to maintain a HP of at least 7 in a patient who does not have any cardiac disorder. In a patient who's got an underlying cardiac disorder, he should have a hemoglobin of at least 8. So the first order of business after you get in cannula and start fluids is to arrange blood and maintain HB above 7. Now, the following slide, I'll show you an endoscopic video. So if you focus carefully on this video, I apologize for the content. So this is taken from the ICU. That's why there is no clear recording. It's a shaky video. But if you look at it carefully, you can see there is a spout or an outpouring of blood spurting from an ulcer in the level of the stomach. And the next step, you can see me using an accessory to try to control this bleeding. The bleeding is happening continuously, but endoscopically, I'm trying to get a hold of this. This is called endoscopic hemoclipping. So we've already discussed multiple times what are the different modalities of containing or obtaining hemostasis in patients with ulcer bleed. So here you have to carefully make sure that once I place in the hemoclip, I wait for a bit before I'm sure that the bleeding has stopped, and then I deploy the clip. This is the metallic clip that is being placed. So as soon as the clip has been placed, the bleeding has stopped. The clip is in place. You can actually see the small blood vessel that is jutting out also. So as always, this is the most common thing about ulcer. You have to mug this up. The forest classification, you're going to have at least one question in some form or the other, especially if you get into the interview phase. This is going to be very important. So the image that I showed you is a forest class 1A, that is a spurting arterial bleed. Why this is important is that the last two in forest, that is the type 2C and the type 3, that is the flat fixed pigmented spot and the clean ulcer base, has got very low risk of rebleeding. So these patients can be, endoscopy can be done in the ER, have a short daycare admission, and you can send them an oral proton pump inhibitors. Everybody else, you'll have to admit them and give IV infusion of PPI, usually pantoprazole. So on the left, you have a spurting 1A. Here is an oozing, that is 1B. This is a 2A, that is a visible bleeding vessel. This is 2B, that is an adherent clot. This is a flat pigmented spot, and this is a clean based ulcer. So a clean based ulcer and flat pigmented spot, you don't have to do any endoscopic therapy. For forest 1A, that is the spurting, the forest 1B, oozing, and the visible bleeding vessel, you have absolutely no doubt that it will have to be tackled endoscopically. Even if a visible blood vessel is seen, if there is no active bleeding also, you have to tackle it. The adherent clot, there is some confusion in the guidelines, but you will be justified if you say that you will endoscopically manage this. Some guidelines are slightly more aggressive. They say that you have to remove the clot and then find out the underlying blood vessel and categorically treat it. But you can even say that I would like to go about it on a case-to-case basis. Whereas for a flat pigmented spot and a clean-based ulcer, you're not going to do anything. Even if your endoscopy technician inject, you're not going to do anything because the clean based ulcer has got a very, very low rate of rebleeding. Now, this patient is hemodynamically stable. You send him to the ICU, but the following morning, you get a call. The patient develops a repeat bout of hematemesis and becomes hemodynamically unstable with a BP of 70/50. You immediately involve your interventional radiology team for a salvage procedure. The following images will describe the step. So, what is this? So here you see a blush of contrast. So this is done by interventional radiologists. This is not done by interventional gastroenterologists. Here they get access through an arterial entry into the gastroduodenal arcade. Usually the bleeding happens from one of the branches of the celiac trunk. So here you can see a blush of contrast that is leaking after contrast dye has been injected. And once the contrast leak has been identified, the radiologist, what he does is pass in multiple coils within. So this concept is called DSA, that is digital subtraction angiography plus coil. Now, it's called digital subtraction angiography because it subtracts the other bony structures and fleshy structures to make sure that the radiologist is able to see only the vessels. So it is a high definition X-ray or a high definition CT angiography, and the process of containing the bleeding is called coiling. Coming to the third scenario, a 56-year-old male patient presents with features of obstructive jaundice with evidence of biliary obstruction on ultrasound abdomen in the form of dilated IHBR. So IHBR is intrahepatic biliary radical dilatation, that is IHBRD. A CT imaging done outside was reported as a bulky pancreas causing bile duct obstruction on the lower end with the possibility of carcinoma head of pancreas. However, what you do is the images, you ask your radiologist to review with it, and your radiologist looks at the images and tells you that she doesn't think it is carcinoma pancreas. She thinks it's possibly a benign pathology, and she asks you to send a single blood marker to confirm her suspicions. The following are the imaging findings. What could be the marker that your friend suggested? If you look at the images, this is the liver, this is the pancreas, this is the dilated bile duct as well as the dilated gallbladder. So there is definitely a structure or an obstruction at the level of the lower bile duct that is causing a dilatation of the bile duct. The same image can be seen on MRCP, in which you can see a thin pancreatic duct which is normal and a hugely dilated bile duct with a tapering at the lower end. Now, the tumor marker that the radiologist friend of yours suggested is serum IgG4. So if you get a question like this, you should know that one of the closest mimickers, but a very rare condition of carcinoma head of pancreas is IgG4 related disease. In IgG4 related disease, which is also associated with a condition called autoimmune pancreatitis, you can have biliary obstruction, which mimics a carcinoma head of pancreas. Why is it so important to differentiate between this? Is it easily treatable disease pancreas and it has got a better prognosis. You can manage it with immunosuppressants like steroids. Now, fun fact for you, the newest drug that is approved is inebilizumab, which is a CD19 plus B cell depleter. This was published in the NEJM in 2025 as part of the Mitigate trial. So close differential in elderly patients of CA head of pancreas, a benign differential is IgG4 disease. Coming to clinical scenario number 4, a 50-year-old male presents to the ER with high-grade fever, jaundice, and high-colored urine. Biochemical investigations show obstructive jaundice with elevated CRP and procalcitonin. An ultrasound imaging shows a dilated CBD and a PD. What classification is used to grade the severity of the syndrome? So the entity that we are talking about here is a combination of fever, jaundice, and inflammatory markers, and you're sure that the jaundice is due to an obstructive pathology. So this technically becomes a diagnosis of acute cholangitis. Now, the Tokyo classification is the age-old classification that repeatedly gets updated, that is being used for diagnosing both acute cholangitis as well as cholecystitis. It will help you in diagnosis as well as prognostication based on the grading of severity. Now, the following is the CT image. What is the etiology of the biliary obstruction? So if you look at this axial cut of the CT, if this is the anterior aspect and this is the posterior aspect, here is the liver on the right side. You have the stomach here. At the center, you will see that there is a classical double duct sign. The bile duct is dilated as well as the pancreatic duct is also dilated. But there is something obstructing the pancreatic duct, that is pancreatic ductal stone. But in this situation, the stone is not only causing obstruction to the pancreatic duct, it is causing obstruction to the biliary system also. And as a result of the biliary system getting obstructed, you have a back pressure rising all the way up to the gallbladder, which is also distended. So how are you going to treat this patient? So this is a diagnosis is chronic calcific pancreatitis. So in CCP, very commonly you can have extrahepatic biliary obstruction. It is one of the reasons for benign biliary strictures. How are you going to treat this patient? Since this patient presented with cholangitis, that is fever, they have to be started on antibiotics, IV fluids, and you have to drain the system as early as possible. The technology that we use for that is ERCP biliary drainage. So if you look at the ERCP image, this is the long ERCP scope or the duodenoscope that we use to get access into the biliary system through the ampulla. You can see my guide wire going inside. Right next to that on the fluoroscopy spot, you can see the large stone which we saw on the same CT. So once the stent is placed, you can see the stent that is gone inside the biliary system past the obstructing stone in the pancreatic duct. The next scenario is a young male who has been on alternative medications for the past 3 years for chronic weight loss and diarrhea. He presents to the ER with recent onset worsening of symptoms in the form of recurrent vomiting and abdominal distension. A CT enterography confirms the diagnosis once it shows an obstruction at the level of the ileocecal junction. After stabilizing the patient for the first few days, you perform the following procedure for the ileocecal narrowing. What is the classification that is used for describing the phenotype of the disease and what procedure is being done? So here you see a narrowing at the level of the ileocecal junction, and you see a balloon being dilated at the level of the ileocecal junction. So this is me passing the catheter and the balloon across the ileocecal junction, and this is the dilatation. So the classification that is used is Montreal classification. The disease, as all of you would have suspected, is Crohn's disease. So we see a lot of Crohn's disease where patients are being treated as IBS. They will present to you with iron deficiency anemia, weight loss, chronic diarrhea, unexplained fever sometimes. So Montreal classification, I'm not going to go into the entire details of it, but it is something that you all need to know, at least the basics, because this is how the phenotypic description of Crohn's disease is performed. And the procedure that was done is endoscopic balloon dilatation based using certain instruments called CRE balloons, that is controlled radial expansion balloons. So these balloons come at the added advantage of decreased risk of perforation. You can do it under vision and you can control the level to which you apply the dilatation to a stricture that you find. In the next scenario, a patient of compensated cirrhosis has been referred to you for chronic iron deficiency anemia. He has been evaluated elsewhere with a contra-CT abdomen, an endoscopy, and a colonoscopy. The CT reports as features of CLD, but no major vascular abnormalities. In the OGD, it is mentioned that there are no esophageal varices. Rest is normal according to the prior OGD, and colonoscopy is normal. So your colleague somewhere else has referred this case to you because you work in a higher center, and there is a possibility of doing something called a capsule endoscopy. A capsule endoscopy, as we have all discussed before, is basically an imaging modality that you do to evaluate the small intestine in cases in which you are doubtful that this patient has got an underlying source of bleeding in the small intestine. So this patient has had an OGD and they have ruled out varices, even though he's got CLD, and colonoscopy is also normal. A CT also is reasonably normal. However, despite your role to do a capsule endoscopy, what the guidelines say is that when you're being referred a case like this, it's always better that you do a reevaluation before you do a capsule endoscopy. One, because capsule endoscopy is a very expensive test. Secondly, in very rare situations, you can have dangerous complications of capsule endoscopy, one of which is capsule retention. Because if you have a narrowing at the level of the small bowel, the capsule can get intact there and you might need to do a surgery to remove it. So you decide to do an upper GI endoscopy, and you're pleasantly surprised to discover this finding on upper GI endoscopy, which was probably missed before. How will you treat this condition? So in this image, you see the antral area of the stomach. You see some blood spots here, but this is the classical presentation of what we call the so-called watermelon stomach or the gastric antral vascular ectasia. You see small linear arrays of bloody spots here. So these patients will not present to you with your classical upper GI bleed or your melena or hematemesis. These patients will present with slow bleeding. Their stool occult blood can be positive, however, they might not have melena. So you should always think of this. And because GAVE is something that you need experience to figure out, it's better that you always do an endoscopy for these group of patients. The therapy that we do for GAVE is either argan plasma coagulation, which is what we have done for this, which is a thermal technique, no contact thermal technique that we use to burn these blood vessels, or for severe nodular thickened GAVE, we can do something called endoscopic band ligation, similar to what we do for esophageal varices. In the next scenario, a patient of severe acute necrotizing pancreatitis is currently in the ICU with recurrent fever spikes. So I hope it's okay that I deal with the questions at the end. So what you guys can do is that whatever questions that you come across, you can put it in the chat box, and I will deal with everything in the end. Is that okay? All right. So a patient of severe acute necrotizing pancreatitis is currently in the ICU with recurrent fever spikes and raised inflammatory markers, despite multiple broad spectrum antibiotics. The following is the CT image. How will you describe this finding? So this is a large necrotic collection, which is a walled off necrosis that is seen within the lesser sac. Now, what is the lesser sac? That is the area behind the stomach. So here you can notice that the stomach has been pushed anteriorly because of this large collection. This is where a normal pancreas is used to be. But this pancreas has been completely destroyed by the process of necrotizing pancreatitis, and you have a large collection that is going all the way towards the left pararenal space. Also, the kidneys are also surrounded by the inflammation. It's a very bad situation. So what happens? So the name of this collection is called a walled-off necrosis. Now, a multidisciplinary discussion decides to drain the pancreatic collection. As you are the senior most gastroenterologist, they ask your opinion regarding deciding between endoscopic and radiological means of drainage. After considering certain factors, you decide to do the following procedure, which I'm going to show. And what is the name of the procedure? And prior to that, how did you decide that an endoscopic procedure is better than a radiological procedure? So here you see on EUS, a large hypoechoic collection. You see me using a needle to puncture this collection, I'm passing a balloon across this and I'm placing a plastic stent to empty the collection. This procedure is called endoscopic cystogastrostomy. Now, two factors that I used to make a decision that I'd go ahead with this rather than a radiological procedure or a percutaneous drainage. One, the duration of the disease. If the patient has been having pancreatitis for more than 4 weeks, then most likely these patients will have a well formed wart, making it very easy for me to do an endoscopic procedure. Secondly, the most important factor is clinical and hemodynamic stability. So, if my patient is very sick on multiple inotropes on ventilator, unable to be shifted, and the anesthesia risk is also very high, it is much easier for me to ask my radiologist to do a percutaneous drainage of the collection rather than do an endoscopic drainage because the anesthetic risk may be slightly lower in the percutaneous procedure. So, very, very sick patients, we ask our radiologists to do drainage. But once they're out of the entirely very sick phase and the number of weeks has crossed more than 3 to 4, we can do endoscopic cystogastrostomy. The next scenario, your oncologist refers a case of metastatic biopsy-proven carcinoma of the pancreas who is on palliative care. He is currently suffering from severe continuous abdominal pain. What is the intervention that he's expecting from you? So this is a patient who you have already diagnosed and sent to the oncologist. And this patient is on palliative or hospice care. The pure reason that your oncologist has referred back to you is he wants to know if there is any way in which you can control his abdominal pain. So, as a palliative procedure, what is it that you can do for this patient? So, you look at the image on the left. Here, you have the aorta. This is an image that you get on endoscopic ultrasound. This is the celiac trunk rising out of the aorta, and this is the superior mesenteric aorta artery that is rising out of the aorta. With this anatomical background, you can closely watch what is happening on the screen here. This is an endoscopic ultrasound image. The same image is being portrayed as a video here. This is the aorta that you're seeing. What the endoscopist is trying to do is target the celiac plexus that is located right adjacent to the celiac artery that comes out of the aorta. So the needle has crossed across and punctured into the celiac ganglion, and I'm injecting a combination of absolute alcohol and bupivacaine to reduce the chance of pain in this patient. So this procedure is called celiac plexus neurolysis. We've already discussed this, but suffice it to say that celiac plexus neurolysis is done mainly in the setting of as a palliative procedure in unresectable carcinoma pancreas with severe debilitating pain. It used to be done for chronic pancreatitis associated pain, but because of its low efficacy rates in the setting of chronic pancreatitis, it is no longer suggested by guidelines, but we do sometimes on a case-to-case basis perform celiac plexus neurolysis for chronic pancreatitis. The next scenario is during an ERCP, you come across the following finding on the cholangiogram. What is the finding? So if you look at this, this is my endoscopy or the ERCP scope that is placed in the duodenum. A guide wire has passed into the bile duct. This is the left ductal system. And you see two large filling defects, which appear as black defects within the bile duct. So this is a definition of a difficult or a large CBD stone. Now, the definition of a large CBD stone, according to most guidelines, is something more than 15 millimeter diameter. Why is this important? Because the chance of recovering stones from the bile duct on ERCP, when the size is less than 15 millimeter, the chances are very, very high. You can use conventional techniques like balloon sweepage or basket to remove this. However, in this case, despite multiple conventional attempts, you are unable to remove the stones. What are the multiple options available to you to remove large CBD stones, and what procedure is being done in the next image? So if you look at this image, on the side screen, you see the endoscopy image in which I am passing another small scope within the bile duct. And this is the view from within the bile duct, where I can see a stone right in front of me and I'm using a probe to fire something at it. This is a cholangioscopic laser lithotripsy. So one of the techniques for performing or taking care of large CBD stones is something called lithotripsy. Lithotripsy can be done either from the outside or from within. If you're using shock waves from outside the body to burst the stones, you do something called an ESWL, that is an extracorporeal shockwave lithotripsy. This can be done for pancreatic stones, it can be done for biliary stones, and it's usually done by urologists for renal stones also. Now, if I do a lithotripsy within the biliary system, not extracorporeal, we can use two technologies. One, I can use laser, as was showed in the prior image, or I can use electrohydraulic lithotripsy, where I use a water jet to puncture or burst the stones. Two other techniques that we use for very large stones is one, mechanical lithotripsy, that is, we crush the stones with a large basket. Or another technique is we do something called an endoscopic papillary large balloon dilatation. So we use a 15 mm or a 20 mm to open up the bile duct but from below the sphincter, and then we draw down the stones with a balloon. Now, the next scenario is a 74-year-old female who presents with insidious onset of jaundice and loss of appetite. Biochemical investigations suggest an obstructive pattern of jaundice. So we know again this is a case of biliary obstruction. A CT scan confirms the level of obstruction and the probable etiology. What is the classification that is used for categorizing the level of obstruction, and what is the finding on the CT scan shown next? So a case of extrahepatic biliary obstruction, patient has got obstructive pattern of jaundice and loss of appetite. So if you look at this image, you can see the liver on the right side. This is the stomach. This is the spleen. This is the anterior part of the body. This is the posterior part with the spine. I draw your attention to this area, which is the hilum of the liver. Here you see a hypoechoic, a hypodense structure or a hypodense area on the right side of the liver as well as the left side of the liver. And here within this hypodense area, you see something called a separation of ducts. This is a classical feature of something called a hilar cholangiocarcinoma or a perihilar cholangiocarcinoma. So that means right at the center of the liver, you have something growing that is causing a separation of ducts of the right ductal system as well as separation of ducts of the left ductal system. The classification that we use for this definition of cholangiocarcinoma is called Bismuth classification. So in a type 1 perihilar or hilar cholangiocarcinoma, the tumor will be located below the confluence of the right and the left hepatic duct. In type 2, the tumor will almost reach the confluence, but it does not extend either into the right or the left hepatic duct. In type 3A, the tumor extends into the right hepatic duct. In the type 3B, it extends to the left hepatic duct. And type 4 is very advanced disease in which you have both lobes that are involved. Why is this important? This is important for the surgeon to plan hepatectomy and to see if it is resectable or not. And it is also important for the endoscopist if he has to go in and drain the system for any purpose if the patient is in cholangitis. Because unless you know which anatomy of the biliary system is involved by the tumor, you wouldn't know in which system you will have to drain using stents. So Bismuth classification is as important as forest classification. Again, this is something that you can read up more on. So in the image, you have separation of a left and right ductal biliary systems, and the diagnosis is perihilar cholangiocarcinoma. So the next scenario is a very elderly gentleman who presents with long-standing dysphagia and halitosis with regurgitation of undigested food. So he's got bad smell, he's got dysphagia, he's got regurgitation. So this is something slightly different from a diagnosis of an achalasia cardia. So your senior gastroenterologist suspects a particular diagnosis and asks for a barium swallow before he goes and does an endoscopy. Now, why is this particular sequence followed is what you are wondering. So this is the finding. On the left is the image. And here you can see the video of this where there is holdup of barium at the level of the neck. It is going into a diverticulum which empties out later. This is the classical image of Zenker's diverticulum, where you have an outpouching between the inferior pharyngeal constrictor and the cricopharyngeus muscle due to it's a pulsion diverticulum. So the reason why we do not immediately do an endoscopy in cases in which we suspect the Zenger's diverticulum is because we are afraid of a risk of perforation. If you accidentally push the scope down the throat, and instead of going into the lumen, if you go into the diverticulum and apply pressure and air there, you can rupture the diverticulum and you can have a nasty situation on your hands. Now, in addition to diagnosis, is there something else the endoscopist can offer to this patient? Yes, it is called Z-poem, which is a variation of poem in which, so if you look at this image, this is the true lumen. And this is the muscle that is holding between the true lumen and the diverticulum. So if you cut across this muscle, then the lumen becomes one with the diverticular opening. So this is called Z poem, where we use endoscopic accessories and current to cut through the muscle and open up the cavity along with the intraesophageal lumen. The next scenario, a neurologist has referred a case of advanced progressive supranuclear palsy in view of worsening dysphagia and choking to get your expert opinion for feeding purposes. So a gastroenterologist has got a lot of role, especially in advanced neurological conditions, progressive dementias, patients with risk of aspiration pneumonia. Sometimes they ask us to place temporarily Riles tube feeding because they'll be suffering from stroke, which is a reversible condition in certain situations. But in progressive dementia conditions, you usually assess whether the patient is fit for something called a percutaneous endoscopic gastrostomy. This is called a PEG procedure, where a direct lumen is created from the stomach so that feeding can be performed for this patient directly through the anterior abdominal wall. So in the next image is a clean procedure. You puncture the stomach from the anterior abdominal wall and you place a bolster inside. There is a bolster outside. The patient can go home with feeds. Now this patient has gone back. The patient does well for a few months. However, they present to you back after a few months with pain abdomen at the site of PEG placement. So when you look at the anterior abdominal wall, you find out that it seems to be stuck and tight, but you still see the PEG tube there. So you decide to do an endoscopy to see if the internal bolster is also okay. But you're really shocked to find out that you can't see anything in this. The PEG tube is not visible. What is this complication term? So some of you must have heard of this. This is called a buried bumper syndrome. So in certain situations, after you place a PEG tube, when you're putting too much pressure on the external bolster or the caregivers are not giving too much attention to it and applies unnecessary traction to the PEG tube, sometimes there can be external traction and the internal bolster of the PEG tube can get buried within the wall of the stomach. This is called a buried bumper syndrome, which is one of the rarest but very scared side effects of a PEG placement. So you always have to give clear instruction to the caretaker that you do not apply high pressure to the PEG. Once a buried bumper syndrome is diagnosed, there are endoscopic and surgical ways to deal with this, but that is beyond the remit of this lecture. So in the next scenario, you receive a consultation from the internal medicine department for a young male with weight loss and iron deficiency anemia. He has been managed for IBS for the last few months prior to this presentation, but currently the internal medicine fellows have figured out that this patient has got weight loss and iron deficiency anemia. So they evaluate this patient and involve you also in this because this patient CT scan and colonoscopy has to be done to rule out causes for iron deficiency anemia. So you have ordered these tests and these are the images of the contrast CT abdomen or the CT enterography. Here, if you notice carefully, most of the bowel loops appear normal. So these are the normal bowel loops. I hope you can see my arrow. This is the neutral contrast that you have placed at the level here. And these are the bowel loops that are reasonably dilated. But if you look at certain bowel loops like this one, there is significant wall thickening here causing luminal narrowing. The same goes for here as well as here. You see the wall thickening of this small intestinal bowel loop. It is way, way more thickened than a normal bowel loop. So focus very carefully on this scrolling video of the CT of this gentleman. So here, if you look, one particular bowel loop is so thickened that it causes luminal narrowing. And you can see that the entire wall is thickened. And finally, it becomes dilated here because it leads up to even further narrowing on. And these are features very, very classical for Crohn's disease, in which you can have small bowel involvement as well as large bowel involvement. Subsequently, we perform a colonoscopy for this patient. So try to etch this image into your heads. These are images of a very clear cut but advanced case of Crohn's colitis. If you see this image, the first thing that should come to your mind is Crohn's disease. You see multiple linear ulcers. These are geographic ulcers. There are skip areas of normal mucosa in between. It's not a very bloody scene as opposed to an ulcerative colitis, which I will show in the next clinical scenario. So these linear ulcers with pseudopolyps in between, lot of debris here. It seems like a distorted colon. These are classical features of Crohn's disease. Now, the patient reviews with you after the biopsy report of the colonoscopy. The following is the photomicrograph of the histopathology slides. What is the final finding on histopathology that clinches the diagnosis? So if you look at this, these are biopsy pictures of Crohn's colitis. So these are inflammatory cells, the blue cells that you're seeing within the colonic mucosa. But the classical feature is an ill-defined granuloma, which is non-caseating. So if you have microgranulomas and non-caseating granulomas, ill-defined granulomas, they are very classical of Crohn's disease. Whereas large granulomas, well-defined granulomas, and caseating granulomas go in favor of tuberculosis. So this is a diagnosis of Crohn's colitis with an ill-defined non-caseating granuloma. Another thing that you should know at your level is that not finding out a granuloma in the setting of a Crohn's disease does not mean that the diagnosis is not Crohn's disease. It is only in around half the cases, sometimes even less, depending on the level of pathology expertise. It's only in less than half the cases that you will get classical microgranuloma or ill-defined granulomas in Crohn's disease. So the diagnosis of Crohn's disease is all about using all the information that you have, stack it up. Clinical history, examination, iron deficiency anemia, elevated fecal calprotectin, high CRP levels, features of Crohn's disease on small intestinal and large intestinal enterography, a colonoscopy or an upper GI endoscopy showing features of Crohn's disease, and finally, the nail in the coffin would be the histopathological features. So you need all these together and the duration of the disease. So even if all these things come together with the person having disease duration for less than a week, you would still be suspicious about making a diagnosis of Crohn's disease. You would keep them at follow-up. Now, the next scenario is a known case of ulcerative colitis who is on regular treatment. Now, he presents to you after a period of clinical remission. Now he presents to you with multiple episodes of lower GI bleeding that is not responding to a trial of oral steroids. The first time he comes to you, you give oral steroids, and again he comes. So first step that you do after this is you rule out Clostridium difficile infection. You check a stool test to see if there is C. diff infection, because it is one of the most commonest super infections. As the next step, even when the patient is not responding to treatment, you order a limited sigmoidoscopy and take biopsies to rule out a specific infection. Which test are you ordering for? So this is the sigmoidoscopic image of this patient of yours who is not responding to steroids, who is negative for Clostridium difficile. In a scenario like this, we would do only a limited sigmoidoscopy because it is so aggravated that if you run the risk of doing a colonoscopy for these patients, you may end up perforating the colon. So with limited amount of air, preferably colonoscopy, CO2, you do a procedure called as a limited sigmoidoscopy and you take biopsies. But what else am I taking other than just biopsies? We are specifically looking for something called CMV, tissue quantitative PCR. This is very important for you to understand. Two super infections that you always have to think in the setting of ulcerative colitis is one, Clostridium difficile, which you can diagnose on the basis of a stool examination, and CMV infection, which ultimately you need either a tissue biopsy with an immunohistochemistry, or you can specifically send for a CMV PCR. All right, so that brings to the, I think, yes. So before we discuss more, so let me look at some of the comments here. Yeah, so that's correct. Type 3 achalasia it belongs to the group of spastic esophageal disorders, similar to diffuse esophageal spasm. Now, since you asked, I didn't want to go into technicalities. So Uh, what you should understand about spastic esophageal dysphasias is that here the problem is that there is contractility. Sometimes there is even hypercontractility, but it's a very erratic, premature contraction that is happening. So there are techniques in which you can use an esophageal manometry to find out that the esophageal wave that is supposed to come at one particular point, if it comes slightly earlier than that, that is when you make a diagnosis of a diffuse esophageal spasm or a spastic esophagus. So type 3 achalasia it's very rare. It belongs to a spastic esophageal disorder. Type 1 is an aperistaltic achalasia. Type 2 is when you have pan-esophageal pressurization. So in most of our practice, the most common achalasia that you come across is type 2 achalasia. So in the case mentioned, a CKD patient and hemodynamic stability, why blood ahead of? So by BT, I am assuming that it is blood that you are asking. So the reason why we are giving blood to this patient is the HP has to be maintained at least to the level of 7 before you do an endoscopic procedure for this patient. So this is based on the American guidelines as well as the European guidelines. You have to maintain a hemoglobin level between 7 and 8. In patients who do not have underlying heart disease, in patients who have underlying heart disease, you have to maintain it more than 8. In hemodynamic instability, you can arrange blood, but if the patient's HP is more than 10, you can arrange blood. But more important than giving blood in this situation is to do an emergency CT angio to find out if there is active extravasation from any of the vessels. So when to do surgical necrosectomy versus US cystogastrostomy, it's not a question that can be answered as a single note, but I'll give you a short précis about how to approach necrosectomy in patients who have very bad necrotizing pancreatitis. The first thing that should know is surgical necrosectomy is done very rarely these days. So it's always been one of the first line therapies historically, but these days, primarily we do something called a step up approach or a minimally invasive procedures. We try to go in from an endoscopic approach or a percutaneous approach. If the patient does not respond to that, finally we go in for surgical necrosectomy because it comes with a very high risk of increased mortality. So in patients in which you have performed US hystogastrostomy and you still haven't responded to these patients, the patients still not responded to this, that is when you send for a surgical necrosectomy. So you have to think of a step up approach in the management of pancreatic necrosectomy. Yes. So anybody else has any doubts, you can chat or ask. Sir, if patient suddenly deteriorates with necrotizing pancreatitis with gas formation, then what should we do? First US or first surgical? So by gas formation, you're talking about presence of air within the collection. First of all, if there is perforation, and we are not talking about perforation within uh, the air cavity within the collection. If you're talking about perforation, obviously there is no role for endoscopic management. The surgical rules remain the same. If there is intestinal perforation, you have to take this patient up for surgery. But if there is a collection with presence of gas formation inside, which is a definite sign of an infected necrotizing collection, you can still do an endoscopic approach or you can do a percutaneous approach. Just because gas inside the mass, by inside the collection, there is no requirement for surgical necrosectomy. So you should understand that gas inside a collection is not similar to pneumoperitoneum. Pneumoperitoneum means that bowel perforation has happened. That is something that we cannot manage. That's where you need the surgeon. If there is gas, we see a lot of necrotizing pancreatitis actually. When we do a CT, we see air within it. In a way, it makes the diagnosis easier because if a patient is asymptomatic and has got a large necrotic collection, we usually don't intervene immediately. But the presence of air within a cavity, a collection, is a short indication that there is infection inside. So in those situations, even if the patient doesn't have pain or fever, we do intervene. And you can do an US cystogastrostomy or a percutaneous cystogastrostomy. Surgical necrosectomy is not routinely done. Can you go to all cases rapidly as revision? Oh my God. Okay. Is there anything to do with hemodynamic stability of patient while choosing between the two? Yes. If the patient is hemodynamically very unstable, you think about it logically. So if you have your patient who's in the ICU and the patient is septic, unless you remove the uh, sepsis, this patient is not going to come out of the shock state that he is in. You want to quickly remedify this situation. You cannot shift him down to the endoscopy suite. You cannot shift him down to a fluoroscopy arena. Obviously, if the patient is that sick, you're going to go for a percutaneous uh, drainage of the collection, not a percutaneous cystogastrostomy. So, cystogastrostomy is internal. You do a percutaneous drainage of the collection, not a surgical drainage. That is even more riskier than doing a cystogastrostomy. Okay. Yeah. So, how to read esophageal manometry graph? So, I purposefully did not go into detail about that because that's very high funda stuff. I mean, I thought it's just enough that you know about. So, okay. So, another person has suggested that if I can go through all the cases again. So, when I do that, I will talk about the manometry also a little bit. Meanwhile, you can put in more questions on the chat box, specific questions, so that I can go through it. So manometry is something it's fascinating. It's amazingly fascinating, and it is. I'll be honest that I'm not one of the experts in manometry, even though I do a lot of poem procedures for achalasia cardia. I personally think that conquering the art of manometry requires more than just endoscopic skills. You need to have the art and scientific spirit of a physicist, I think, because I was recently reading about how they came across, invented this concept of esophageal manometry, how they made the old black and white charts and then tried to make it into 2D and 3D, and they came about it. There are very interesting articles about esophageal manometry, but I cannot go into the extreme details of it, but I'll tell you a gist of it. So this, I'll just go through the images. I'm not going to go through the scenario. So this is a classical case of an dilated esophagus with food stasis inside. So you can see that the mucosa is normal, and you see the rosseting. The rosseting is the folds coming together. That means it's so tight. The muscularis layer there is so tight that it is pulling the mucosal folds towards the gastroesophageal junction. The CART score is the scoring system that you clinically use for assessing the severity. And manometry, I will talk about the different types. This is the abnormal manometry. In this particular case, this is the barium swallow. This is before and after we perform, and this is the initial phase where there is the hold up. On the right, you have a brisk passage. This is a classical sign that we do always do a check radiograph with contrast on the day after we perform a paroral endoscopic myotomy, not to assess for efficacy, but to make sure that there is no leak. Because what we have is we're actually causing a perforation of these esophageal muscle walls and closing it with clips. I actually had all the videos of poem. I thought that it'll be too high funda for you guys. That's why I didn't put it. Maybe next time I can show you all the videos of different steps of paroral endoscopic myotomy. This is a normal barium swallow, and this is a normal esophageal manometry. So I'll just spend 2 minutes on this. So this is a dynamic pressure curve of the esophagus. Here there is the pressure on this axis. On this axis, this is time. This is the upper esophageal sphincter. Imagine that this is the upper esophageal sphincter, and here is the lower esophageal sphincter. So high pressures are red and yellow to a certain extent. Low pressures are blue and green. So normally what happens is there is a sequential gradation of a high pressure wave down the length of the esophagus. But the moment this contraction starts after the upper esophageal sphincter relaxation at the level of the upper esophageal sphincter itself, what happens is there is a drop in pressure at the lower esophagus. That is how smartly our system has been trained. The moment I swallow, my lower esophageal sphincter opens, paving way for the contractile wall. So what you should know at your level is that this lower esophageal sphincter relaxation pressure is obviously a very low pressure normally in me and you. But when you have achalasia cardia, what happens is when I swallow, it doesn't go beyond below a particular level, and that is the integrated relaxation pressure. There, the level remains above 15. So, I'll give you a historical anecdote to help make you understand even more clearly. So, if you look at historically how they diagnosed achalasia cardia, they used to call it cardiospasm because that was the technical term, because people used to know that this condition did exist, but they didn't know why it happened. For a longest time, they thought that it's because there is like hypertrophy or hypercontraction of the lower esophageal sphincter. And that is when a very smart, perceptive pathologist or surgeon during autopsy figured out that if it was due to so much contraction, what happens to human muscles when you have so much contraction? You will have hypertrophy. So when they were doing autopsies, they figured out that the lower esophageal sphincter was not hypertrophy. So that is when that particular gentleman said that this is not a problem of contraction. This is a problem of absence of relaxation. So then they termed it, saying that the esophageal sphincter has forgotten how to relax. And the nomenclature also changed from cardiospasm to achalasia cardia, which in Latin means an absence of relaxation. So that's why, if you want to understand manometry, if you read about how they discovered achalasia cardia as a disease, you will get a better idea. So there is an abnormal relaxation or an inadequate relaxation of the lower esophageal sphincter, and that pressure remains above 15. That is the classical sign qua non of achalasia cardia. Now, how to differentiate between these three, that is type 1, type 2, and type 3? Again, I'm going to say that at your pay grade level. So, all these three, you should know that the manometry IRP level is more than 15. We all agree with that. So, that makes it achalasia. Without an IRP level more than 15, it doesn't become an achalasia, it just becomes a motility disorder. Now, in type 2 achalasia, which is the most common, you see instead of the sequential wave, you have something called a pan-esophageal pressurization. That is, there is an equal amount of pressure distributed throughout the length of the esophagus, which is not a productive wave. For your food to pass down your throat into your stomach, you need to have a sequential wave, which is not here. In type 1 achalasia, there is no pressure. Blue, as I told you, is low pressure. There is an absolute lack of peristalsis. It is an aperistaltic esophagus. In type 3 achalasia, you can see there are pressure waves, but it's not sequential. It's erratic, as in it is coming at a time that is before its time. So this is based on something called distal latency. I'm not going to go into that because it's very super complicated. You just remember that the esophageal contractile wave happens earlier than when it is supposed to. That makes it a spastic type 3 achalasia. I hope that's a little bit clear. Okay, so paroral endoscopic myotomy. Then this is an image of a bleeding gastric ulcer. This is Forest 1A classification. You can see the spout of blood that's coming in. So this is me using a hemoclip to close this. Forest classification, all of you know, all of you should remember it. You shouldn't go inside without. This is 1A, this is 1B, this is 2A, there is a visible bleeding vessel, this is an adherent clot, that's 2B, this is 2C, this is a clean based ulcer, this is a hemocystic spot. And next is, if there is a failure of endoscopic management, you have DSA plus coiling. This is done by interventional radiologists. Here, you have a close mimicker, a benign mimicker of a malignancy. So you would think that this is CA pancreas, but this patient has got an elevated serum IgG4 levels. This patient is suffering from IgG4 cholangiopathy with autoimmune pancreatitis. The latest drug that is approved in gastroenterology is inebilizumab, published last month in NEJM as part of Mitigate trial. The next scenario is a biliary obstruction where you have a pancreatic ductal stone that is causing obstruction of the lower end. So that is cholangitis. You have to treat it with ERCP and biliary drainage. So you should understand that even in chronic calcific pancreatitis, majority of the ERCP procedure that we perform for chronic calcific pancreatitis is not pancreatic ERCP, it is biliary ERCP. There are very specific indications for performing ERCP in the setting of a chronic calcific pancreatitis. So this is DM level stuff, but I'll just be very brief with this. Always understand that just because there are stones within the pancreatic duct doesn't mean you go inside the pancreas, take all the stones out. On the other hand, in the biliary system, if you have stones within the biliary system, even if the patient is asymptomatic, because of the significant risk of cholangitis, you have to take out the stones in the biliary system. In pancreatic ductal system, only when you have a single proximal PD stone or a stricture in the setting of a patient having a symptomatic pancreatic pain, will you perform pancreatic ERCP? So this is a case of Crohn's disease with ileocecal narrowing. Patient present to you with obstruction. So once you manage the obstruction, we do something called a CRE balloon dilatation. A Montreal classification is how you describe the phenotype of Crohn's disease. This is GAVE. So any patient presents you with obscure GI bleed, especially if they have CKD or CLD or systemic sclerosis or any kind of autoimmune pathologies, or even asymptomatic. You should know that the most common cause for gastric antral-valvular ectasia is non-CLD causes. So you would think that it's only CLD that is most important. Actually, the majority, the bulk of GAVE cases do not have CLD. So this is APC that you perform for GAVE. This is a case of acute necrotizing pancreatitis. We already discussed this. This pushes the stomach anteriorly. So this is what I was talking about. So if you look at a percutaneous drainage for the gentleman who asked about the percutaneous versus endoscopic ultrasound guided. So for this patient, if this patient is very, very sick on multiple inotropes, cannot be shifted, cannot do an endoscopy, your anesthetist tells you that you cannot do an endoscopy for this patient, what I'm going to do is send my radiologist who will do an ultrasound guided or a CT guided procedure where they will access through this area. So they will puncture this, dilate this tract, and put in a guide wire and put in a catheter which will drain as much as possible. Now that's an external drainage. Why it is not always preferred and why we go for it in situations when the patient is very, very sick is because an external drainage comes with the risk of something called a pancreatic external cutaneous fistula. Now, pancreatic collections, because they are so thick with the very dangerous secretions of pancreas, that it's very short that these patients will require or develop something called an external cutaneous fistula. Whereas if we do an internal drainage, there is no problem of fistula at all, because what I'm trying to do is put a connection between the stomach as well as the collection. So that is called EUS guided cystogastrostomy. Even in that, there are two forms of EUS guided cystogastrostomy. If the predominant collection is cystic, that is, majority of it is cystic fluid, easily accessible, I will just place plastic stents. However, if there is a lot of thick necrotic debris, I would place in something called a LAMS or a lumen opposing metallic stent. What it will do is connect the stomach and the cyst cavity. At the same time, it will have a high diameter, which will make sure that the thick necrotic collections will empty out into the stomach. So this is the cystogastrostomy. This is on EUS. We'll see a hypoechoic structure, puncture with a needle, dilate the tract, put a balloon, and within that you can put a double pigtail stent. So this is the image of a celiac plexus neurolysis. This is where the celiac plexus will be, and under EUS guidance, we can puncture it and inject it with bupivacaine and absolute alcohol. So this is usually done only in the setting of carcinoma pancreas. This is an image of an ERCP with stones inside, large stones. These are usually more than 15 mm, which is the definition of a large CBD stone. You can use laser lithotripsy or mechanical lithotripsy or endoscopic papillary large balloon dilatation, or EHL, that is electrohydraulic lithotripsy, or the extracorporeal shockwave lithotripsy. This is a separation of the right and the left anterior ducts. This is usually a perihilar cholangiocarcinoma. You should be well aware of bismuth classification. And this is the image in a video of a Zenker's diverticulum, which happens as an outpouching diverticulum or a pulsion diverticulum between the inferior pharyngeal constrictor and the cricopharyngeus muscle. The treatment for this can be endoscopic treatment, that is Z-POEM. The next is PEG placement. This image classical is PEG. So when your PEG patient comes back to you with pain abdomen, when you do a repeat endoscopy, you don't see the PEG internal bolster within. That's called a buried bumper syndrome. These are the classical features of Crohn's disease. And here is the classical thickening of Crohn's disease with the dilatation. And these are the classical ulcers of Crohn's disease. This is the non-caseating ill-defined granuloma, and this is ulcerative colitis. And you always check for superinfections. That is all right. So is there, sir, how to read my, okay, please go through earlier case faster, joined at case 7. Yeah, I hope that's okay. Sir, plastic stent or SEMS, which to done in malignant stricture? There are evidence of SEMS increasing compared to plastic. Kindly enlighten, sir. Excellent. Yes, you're absolutely right. So, but it's not as simple as it sounds. So when you talk about a malignant stricture, so I always tell this to my residents. I hope this is not too, I'm not trying to But whenever you think about your theory scenario, or whenever you're practicing, when you come across, you think about not just the problem at hand, but you think about the problem that you're going to face with later. So when you ask me questions like this, so you're asking me about a malignant stricture. The most important question that you're going to ask is, what is the ultimate natural history of the disease? Whatever field that you're working in, whether you are going to be in internal medicine or gastroenterology or cardiology, one thing that you should train yourself to think like and act like is, you have to understand that the disease that you're going to deal with is probably going to have a future just like you and your patient. What is going to happen to the disease as part of the natural history of the disease? Your job is not to diagnose the malignant stricture, put a stent and go. Your job, the patient is not going to ask you about these things. The patient is going to say, what is going to happen to my husband? What is going to happen to my wife? What is going to happen to my father? So when you look at a malignant stricture, the most important thing before you do even think of an ERCP is this a resectable disease or not? That's a very important question. Second important question, is the patient in cholangitis or not? Is the bilirubin very, very high or not? So you have a resectable periampullary carcinoma, or if you have a resectable carcinoma head of pancreas, the patient's bilirubin is 9 and the patient is not in cholangitis, you have no business doing an ERCP. Even if it's going to be a very difficult ERCP, you do it, you place a stent and the bilirubin comes down by 5 points. You have not done a victory lap. You have made it more difficult for the surgeon to deal with the situation. You have lost valuable time. So indications for performing ERCP in the setting of a malignant stricture is dependent on the natural history of the malignant stricture. So when we place a metallic stent, there are specific situations. If a patient is in cholangitis, yes. If the patient is an unresectable case, the patient is never going to undergo surgery, yes. As a palliative procedure, you will do it. If the patient is borderline resectable CA pancreas and your oncologist tells you that I want the bilirubin to be less than 5 so that I can give a capecitabine or a cisplatin-based chemotherapy, yes, then you place a stent. In that situation, placing a metallic stent would definitely be better than placing a plastic stent, because your response or the growing down of bilirubin would be faster. But obviously the cost will be higher. So as a palliative procedure, you can place a metallic stent. Please add a video of colorectal cancer, one of the case scenario. Nice. Okay, I'll think of that. Okay, that's something that we have not covered. Colorectal malignancies. Malignancies, yes. Okay. Hepatology, yes. Hepatology, our man Tarun will be on the job. So both of us will do more of this. I personally, I am very weak in hepatology. I'm the first person to accept that. I know I don't practice a lot of hepatology, so we'll do something about that. I promise. Yes. Anybody else has anything to say, or we can go and enjoy the weekend? Cholangiocarcinoma also, yes. So that's why I included one slide on cholangiocarcinoma. See, the idea behind this potpourri thing that we did right now, I don't think we should aim to go in depth into it. The idea behind this is to do a surface check, so that we go through different topics, give you a feel of what you have to, especially for the ones who are preparing for the uh, PGI and AIMS, and you're thinking about getting into the interview and smashing the interview. Because I was talking to the guys who got into it last time, and the kind of questions they have asked were much higher level than what I was asked 7 years before, when I mean not 7 years, 9 years before, when I gave. So this is not about going in depth into each topic, but we will include cases. So that's why in cholangiocarcinoma we did have CT image, but we'll try to include more like that. All right. Thank you.